We'll just give it another minute for people to be let in. We'll just give it another minute for people to be let in and for everyone to put it on mute on their own computer. So good afternoon, everyone, and welcome back to the first OC3PR of year 4. Hope everyone had a good summer, are rested and ready to go for another year of our webinar series. Today, we're going to be exploring the management of shock and the role of so-called shock teams. For those unfamiliar with Ontario Critical Care Clinical Practice Rounds, it's a webinar series sponsored by Critical Care Services Ontario. Its goal is to help address the challenges that health professionals experience while trying to provide the best possible care to acutely ill patients. Our webinars aim to address these issues through education and the sharing of best practices. The format of OC3PR provides an opportunity for you, the listener, to submit questions, which today will be fielded by Dr. Bernard Lawless and Josée Thériault, both members of the OC3PR Executive Committee. To submit questions, please type and send them to the individuals named Q&A for question and answer. This webinar, along with previous sessions, are available at both the CCSO website and their YouTube channel. As before, please do your best to keep yourself muted. Please again fill out the survey at the end of today's webinar, as your feedback is greatly appreciated and help us plan future events. Continue to look for upcoming events on the CCSO website and consider following them on YouTube and X. For those who don't know, that's what Twitter is now called, at least for the last month or two, or forever as long as Mr. Musk determines it. Today's discussion, however, is hopefully the first of several, whereby we will explore issues that are of importance to both critical care, but also cardiac specialists. It helps demonstrate how important our collaboration and integration of both discipline is to the care of acutely ill patients. There's no question, though, that the management of shock, including cardiogenic shock, has evolved over the last few years. The introduction of temporary mechanical devices, along with other strategies, such as shock teams, has significantly improved outcomes. Shock teams are often multidisciplinary groups of various healthcare professionals who specialize in the management of shock. Today, we will be hearing about the role of shock teams, including the evidence for them, along with the challenges that goes into creating them. Presenting today will be Dr. Faizan Amin, who was with us and gave us an excellent presentation on ECMO several years back, and Dr. Anthony Main. Dr. Amin is a cardiologist intensivist at Hamilton Health Science. He has an interest in advanced heart failure and cardiogenic shock. He is the director of the cardiac care unit and the medical director of the ECLS program in Hamilton. He is also the co-chair of the Ontario ECLS network. Dr. Amin earned his medical degree from McMaster University, along with his residency training there in medicine, cardiology, and critical care, followed by a fellowship in advanced heart failure and transplantation at University Health Network in Toronto. He is an assistant professor at McMaster University in several divisions, including cardiology, critical care, and education and innovation. Presenting with him is Dr. Anthony Main. Dr. Main is an interventional cardiologist in the Department of Cardiology at Health Science North in Sudbury. He serves as the director of the cardiac cath labs. He received his medical degree from the University of Western Ontario and completed his medicine residency at McGill and his cardiology at the University of British Columbia. He completed an interventional cardiology fellowship at Foothills Medical Center in Calgary, and then a structural heart disease fellowship at the University Hospital, Cleveland Medical Center in Cleveland, Ohio. He is a fellow of both the Royal College of Physicians of Canada and the American College of Cardiology. He's a clinical lecturer at the Northern Ontario School of Medicine. Gentlemen, thank you both for taking the time today, and I'll look forward to the presentation and the discussion afterwards. Faizan, I believe you're starting, and I'll pass it on to you. Thank you both.
Thanks, Dave, and thanks for the invitation back. And it's a pleasure for both Tony and I to present some of our experiences to the group, and looking forward to hearing everybody's feedback and thoughts from your own experiences as well. So the objectives, as were shared with everybody for this talk, really are to initially describe some of the rationale and evidence behind the emergence of shock teams. We will go through some of the operational components using case examples that Tony was kind enough to put together of how multidisciplinary shock teams work in the space of cardiogenic shock. And then from a practical standpoint, what are some of the challenges in implementing these teams, and how do we move forward with such an initiative if you're thinking about it at your institution? Now, I don't think I need to belabor this, but we all know that the mortality of patients with cardiogenic shock is still too high, despite all the advances in critical care and other cardiac interventions that have happened over the last 2 decades. Mortality for these patients still remains upwards of 50% in the sickest population, with acute MI still being the most common cause, along with other causes of acute decompensated heart failure. We've advanced a lot in our ability to provide timely revascularization, our medical therapies within our intensive care units and coronary care units, use of temporary mechanical support, durable mechanical support, and fulsome management of these patients in the ICUs. But despite that, mortality hasn't really budged in the last 1.5 or 2 decades. We know that these patients are extremely heterogeneous in their presentation, even if they present with an acute MI and cardiogenic shock. Not one patient is exactly the same as another. Their clinical trajectories can be different, and so a coordinated and multidisciplinary approach seems to be perhaps the most feasible and appropriate way to intervene on some of these patients to ensure that we can help the patients that are most likely to be salvaged. Many of you have probably seen the SKY staging of cardiogenic shock, which is now widely accepted globally. And this is just to show that as you progress through the stages of cardiogenic shock between stage A or at-risk patients all the way to the most sick patients in stage E or extremis, the mortality on the right-hand side in the bar graph is increased exponentially over time. And the sicker you are with more hypoperfusion, hypotension, the more likely you are to not survive. And so if we focus some of our efforts in this SKY C, D, and E population, we may be able to make some headway and inroads in reducing the mortality in this population, which is part of the rationale for trying to from where shock teams have emerged over the last few years. So when we talk about shock teams, why even think about a team-based approach in cardiogenic shock? Those of us that are already working in the critical care space know that team-based care for critical illness already exists. We work on code blue teams, rapid response teams, stroke teams, trauma services to intervene in a coordinated fashion in a subset of patients. And this sort of notion of team-based care has already been proven effective in different areas of critical care. At multiple heart centers, we already use heart teams that consists of different cardiac subspecialties when we're talking about complex coronary interventions, structural heart interventions, etc. So the premise is already existing, and shock teams have use that premise to apply it to this sick population. The overarching goal of a shock team in cardiogenic shock is really to streamline the systems of care and develop a standardized approach in what is otherwise a heterogeneous and acutely unwell population. We know that there is significant variability in practice patterns in managing cardiogenic shock, whether you use inotropes or don't use inotropes, which type of inotrope to use. Should we, some places are more pro mechanical support. Others are less pro mechanical support. Some places are pro invasive hemodynamics, PA catheters, other hospitals less so. So there is already existing variability in practice. So to streamline that and standardize using best available evidence should help us in improving care for this population. We know that there is a volume outcome relationship when it comes to hospitals that look after cardiogenic shock. For example, in Hamilton, we provide quaternary cardiac care to a population of over 2 million. Similarly, Health Sciences North, where Tony works, has a huge geographic catchment area with a widely heterogeneous healthcare centers within that geographic space. And we know that the more cardiogenic shock you see at your hospital, the more likely patients are to survive as you build your team's experience and increase your case volume. Secondly, a cardiogenic shock team should help with A, early recognition, and then secondly, and B, timely investigations to facilitate appropriate decision-making. One of the downfalls in cardiogenic shock and challenges is always that we recognize it later than perhaps we should. And this has been identified both in Hamilton as well as Health Sciences North, and I'm sure at other hospitals that have reviewed these types of patients in previous M&M rounds, that we've identified delays in recognition. So treatment is often delayed in those patients as well. So with the use of early point of care ultrasound, invasive hemodynamic assessments, sometimes both left and right heart catheterizations, developing an algorithm, a systematic approach helps with earlier recognition. When we recognize these patients in a timely fashion, that allows us to initiate timely interventions, whether it's early revascularization or other forms of interventions, medical support or mechanical support, or in some cases, just comfort care and palliation when appropriate. There is emerging data that in the subset of STEMI patients that present with cardiogenic shock, the time from their first medical contact to intervention is a clear association. There's a clear association. It's a strong predictor of mortality. Those patients that present and are recognized later tend to do worse than those that are recognized earlier and intervened upon earlier. And alongside appropriate recognition and timely intervention is appropriate patient selection, which in many ways is the holy grail in a subset of patients that is already very sick and has a high mortality rate coming through the door. We recognize that we're not going to be able to save every single patient that comes with a pre-existing mortality upwards of 50%. But by using a multidisciplinary team, we can intervene on patients that by consensus are felt to be the most likely to be salvaged. And we also know that the use of multidisciplinary shock teams does not delay time to intervention. In fact, most emerging data suggests that it helps choose patients that are most appropriate for intervention and also identify patients that are not appropriate for intervention. And lastly, beyond just intervening in the cath lab or in the in the OR, inserting devices or starting therapies, we know that these patients have more than just a quick reversible cardiac problem. They tend to have multi-organ dysfunction. Many of them are mechanically ventilated. They sometimes need renal replacement therapy. So part of the function of a multidisciplinary shock team is to provide the care that goes beyond their initial shock. So comprehensive intensive care, helping choosing the right device for the right patient, and then treating not just the cardiac component of their shock, but many times what is hemometabolic shock, with some of their biochemical and other metabolic disturbances that come along with their cardiac dysfunction. We also know that there's often an underutilization of palliative care resources in this subset of population, especially coming through a procedural-based subspecialty. We often focus on trying to intervene with some sort of a device or aggressive intervention, but having a team to back up sometimes what are very difficult decisions in young patients who some folks may feel are salvageable, but by using a multidisciplinary team, we can often help back up our colleagues in making decisions that may be most appropriate for the patient, even if that means palliation. The structure of a cardiogenic shock team typically consists of a cardiac intensivist, whether that's a CCU doctor at your hospital or a CVICU physician, a heart failure cardiologist, which sometimes exists at certain hospitals, otherwise sometimes it's blended in with the intensivist, an interventional cardiologist, a cardiac surgeon, along with anesthesia. And often we have allied health staff that accompany us in our decision making and then carrying out the intervention, most commonly perfusion, and nurses and RTs in the ICUs and Cath labs. Point being that this is just kind of a framework, but it is quite adaptable to what the local infrastructure at your hospital may look like. We recognize that not every hospital has every single subspecialty available, but whatever existing infrastructure and teams, clinical programs you have available at your hospital can be combined into a multidisciplinary team that focuses on the cardiac population. What is the evidence suggesting in terms of the utility of cardiogenic shock teams in their ability to improve outcomes? The largest study that's been published looking at this question was the Papalos and group's trial published in 2021 from the CCCTN group in the US, which compared about 24 cardiac intensive care units in the US, those with cardiogenic shock teams versus those without cardiogenic shock teams. And what they described was the shock team approach that we've described previously here today, with a multidisciplinary team consisting of critical care and heart failure, interventional cardiology, and cardiac surgery, and some form of an ECLS service, which then led to a multidisciplinary evaluation of a patient at a clinical level, followed by invasive hemodynamics, additional diagnostics such as bedside echocardiography, angiography, and then selection of the most appropriate therapeutic intervention. And what was described was that those centers that had a cardiogenic shock team had a significantly lower mortality in cardiogenic shock patients, as well as decreased length of stay in the ICU. Most of these patients were typical cardiogenic shock patients. They had high lactates, high filling pressures, and low cardiac indices on invasive hemodynamic monitoring. This study also found that overall the use of advanced mechanical circulatory support was in fact less in those centers that had a shock team versus those that didn't, which is an interesting finding, perhaps suggesting that having a multidisciplinary team helps make more judicious decisions and more appropriate interventions in patients that are most likely to be salvaged. But that remains to be borne out in other larger studies. One of our fellows and colleagues, Ray Jinnah, has looked at all the existing literature in cardiogenic shock teams. This is unpublished data describing about 15 studies mostly observational, that have looked at survival and mortality data. And it's quite clear that all the papers that have looked at presence of shock teams have shown improvement in survival and reduction in mortality. Beyond that, there is in the middle graph, if you look at in that graph, it's quite clear that those centers that use shock teams more commonly use pulmonary artery catheters for invasive hemodynamics, which is where the evidence in cardiogenic shock is heading, where tailored hemodynamic therapy has shown improvement in survival in patients with cardiogenic shock. Length of stay in the ICU and use of mechanical circulatory support is still somewhat neutral, and we don't quite know what the impact of shock teams is on those outcomes. Perhaps the most useful finding in the existing literature is more about what the qualitative benefits described by the hospitals or stakeholders that have developed shock teams are in the literature. Firstly, they describe the benefits of having a centralized and streamlined system of care for patients with cardiogenic shock. They describe the benefits of having coordinated and collegial support from your colleagues. And I'm sure Tony would vouch for this as well. And we've noticed this as well since we've implemented our shock team. And within our ECLS program, the relationships between cardiology, cardiac surgery, interventional cardiology, intensive care, anesthesia, there's a lot more collegiality. We're way more connected when it comes to converging on a patient and making team-based decisions, which really helps even outside the shock patients. When we're discussing other patients, there's a much stronger relationship between teams, which obviously is very helpful for the morale and collegiality within your group. Having a shock team certainly helps with group expertise. We all learn from each other. Everybody brings a different lens, whether you're an interventionalist or a surgeon or an intensivist or an anesthesiologist. When you're discussing a patient, everybody brings a unique lens, and those that are perhaps the most invested at the moment, we all learn a lot from having each other's opinions at the table, even in a time of crisis. And when we debrief these cases, that's a common theme that does come up. Having a multidisciplinary team where you're forced to make decisions with consensus definitely helps reduce variability. When you're faced with a sick patient and you're scrubbed and you're trying to make a decision that is time sensitive, often it is challenging to make the best decision in the interest of the patient because there's so much going on in a crisis moment. So having a team to help back you make some of the more challenging decisions helps have a more standardized and homogeneous approach to making decisions. It also helps with having guidelines that are more clear for everybody involved in the circle of care, so that there's less variability when it comes to who is appropriate in terms of their candidacy for more advanced therapies versus no mechanical intervention at all. Certainly, earlier recognition and timely intervention is better with a multidisciplinary approach. And again, the concept of having a multidisciplinary team, perhaps the individuals on that team may differ based on where you work, but it is adaptable to all levels of healthcare. So I'll pass it over to Tony to describe a couple of cases, and I can run your slides for you, Tony.
Thank you very much, sir. So for my portion of the presentation, I wanted to focus on two cases that came through the critical care and cardiology services in Sudbury, and just to sort of highlight how we manage these patients after the formation of our cardiogenic shock team. So the first patient that I'm going to present is a patient who came into our service about 6 months ago. She had been admitted to the ICU after having a overdose of multiple medications. She had a drug overdose of crack cocaine as well as clonazepam. Her past history was, she didn't have too much in the way of cardiac risk factors, but she had known bipolar disorder and had underlying alcohol abuse. She was intubated on arrival for reduced GCS and was treated for aspiration pneumonia. She had an AKI, and initially she presented more as a toxic presentation. She had elevated lactate, and she was appropriately resuscitated. However, during her resuscitation, she had a cardiac arrest. She developed ventricular tachycardia. CPR was started, and after a single shock and a dose of amiodarone, return of spontaneous circulation was obtained. And she had a 12-lead ECG that showed diffuse ST wave changes, but nothing diagnostic of STEMI. But given her presentation, she was taken to the cath lab. Next slide, please. She remarkably had normal coronary arteries, next slide, please. But on injection of her LV, she had a dyskinetic anterior wall apex consistent with Takotsubo syndrome. Takotsubo syndrome, for the non-cardiologists on the line, is also known as broken heart syndrome or stress-induced cardiomyopathy. It was first described in a widow who watched her husband pass away in front of her and then told everyone around her she was having a heart attack, was taken to the cath lab, was found to have normal coronaries, but was found to have a severe LV dysfunction. It's named Takotsubo because it resembles a octopus trap from Japan. Anyway, this patient was taken to the cath lab and we did a right heart cath on her. She had a very elevated wedge pressure at 34. She was in cardiogenic shock. Her index was 1.7, and this was her being on IV epinephrine and IV Levofed. Some other cardiac right heart hemodynamic numbers that are routinely used in cardiogenic shock these days to help determine what type of shock, whether it's single ventricular or biventricular, and whether or not mechanical support is indicated, is cardiac power and PAPSI, pulmonary artery pulsatility index. Both of these markers were reduced in her. So at this point, it was 1 a.m. and a shock team consult occurred. Members of the team who were present included interventional cardiology, critical care, cardiac surgery, our perfusion colleague, and anesthesia. We agreed that she was in cardiogenic shock. Based on her cardiac power output and her PAPI, she probably should have been considered for RV support. However, we don't have any dedicated RV devices at our institution. It was thought, though, that this was primarily an LV problem, and that if we supported the left ventricle, that we would probably also be able to support her right ventricle. So the decision was to place Impella, and that if she deteriorated, we would moving to ECMO. So the Impella was placed in the cath lab. The patient was taken back to the ICU, and within the next 24 hours, her lactate completely normalized. She was weaned off all of her pressors in the next 72 hours. She was kept intubated, and over the next 7 days, she would have regular echoes. Her biventricular function improved. She had daily rounds by the interventional cardiologist, the ICU attending, as well as perfusion. We were able to successfully explant her device on day 8. She was extubated 2 days later, and she was subsequently transferred to a rehab center. She was seen at 3 months follow-up, and she's been doing very well. Her repeat echo shows preserved biventricular function. She started going to rehab for drug addiction, and she's actually made a very meaningful recovery. So this was a case where we were able to find an appropriate device for a patient who we thought was salvageable, and we actually had a very good outcome. It was very multidisciplinary. The second case I wanted to present was actually a case just this past week. It was actually, I think Dr. Thériault was still on the line. It was a case that we did together. It was a 76-year-old gentleman. He had a past history of alcoholic liver cirrhosis. He was the Child-Pugh C, and he had a severe dilated left ventricle with reduced biventricular function. His EF was 15% on an echo. He had had a cath in the days leading up to his decompensation that showed moderate coronary disease. And on his echo, he also had severe aortic regurgitation and severe tricuspid regurgitation. He was on the hospital ward, and he was noted to be hypotensive and was found to have an elevated lactate. Next slide, please. So he was transferred to the CCU. He was started on Levofed and dobutamine. And it was at this point that he was taken to the cath lab for a right heart cath. So he also had a very elevated wedge pressure. He had pulmonary hypertension, and he was in cardiogenic shock with a reduced index. So again, we had a shock team discussion in the late evening. And so present for this one was critical care, interventional cardiology, perfusion, and interventional cardiology. And unfortunately, it was thought because of this patient's severe biventricular dysfunction, his state of shock, and the fact that he wasn't a surgical candidate or a TAVI candidate, that we would just optimize medical therapy. Given his severe AI, he wasn't a candidate for any mechanical support. So we decided just to treat him with maximal medical therapy, so inotropes in the CCU. Next slide. So after a few days of medical therapy, the patient asked to be made to do not resuscitate, but still wanted to continue with medical therapy. The patient started to develop VT, and after 72 hours of no improvement, this is someone who unfortunately we couldn't salvage, but we were still able to give him sort of an appropriate, management for his end of life. He passed away peacefully, surrounded by his family. So even though in this case, the fact that we had a multidisciplinary team, that we were able to identify him early and assess him hemodynamically with a right heart cath, still shows that even if not everyone ends up being salvaged with mechanical circulatory support, that there's still a very good role for the shock team in cases like this.
Thanks, Tony. I can kind of carry on and just to kind of wrap up the talk with some of the practical steps that we've taken at our respective institutions when coming up with the process to implement a shock team. Firstly, I think it's important to define what your target population is. We don't want to develop a system wherein we're adding redundancy in what would otherwise be, straightforward existing processes of care. So at our institution, we're mainly targeting the SCI D and E patients. We do sometimes discuss the SCI C patients, but if they're stable, not declining, then we have an existing process through the CCU where those patients are flagged. But we mainly want to target those patients that are declining despite early intervention. Those patients that are otherwise in persistent shock, and for all practical purposes, any patient that we would otherwise consider for hemodynamic support, when that question is raised about the need for hemodynamic support, that should trigger a shock team discussion. So through work that's been championed by one of my colleagues, another cardiac intensivist with us, Mike Tsang, he has developed a very comprehensive protocol. And just to kind of highlight some of the themes, our team consists of, on the top right side, you can see that our team consists of interventional cardiology, CVICU, cardiac surgery, CCU, and heart failure. On the left-hand side, we have some basic triggers for activation along with exclusions. So patients that are over 70 years old, otherwise not expected to survive, have other standard sort of comorbidities that would deem them too ill for a major intervention or surgical procedure. That serves as a standard baseline for initiating the shock team process. Once the shock team process is initiated, through the middle of the diagram, the flow chart, you can see that our focus is on trying to phenotype the patient based on whether they have LV failure, RV failure, or biventricular dysfunction, which involves doing a number one bedside echocardiogram, point of care ultrasound, which can be done anywhere, whether they're in the CCU, in the emergency room, or in the cath lab, as well as early invasive hemodynamic data through a right heart cath or SWAN. So we're able to then also, once we phenotype those patients, we also take as detailed of a history as is possible at the time, and try to ensure that there are no clear contraindications such as severe renal dysfunction, hepatic dysfunction, coagulopathy, or perhaps other cardiac disorders like major valve disease, mitral or aortic. And once we phenotype those patients, the shock team discussion happens, where data is presented quarterbacked by the CCU physician. And based on the clinical parameters and the hemodynamic parameters, decision is made about whether to proceed with just medical therapy and palliation, or trial of medical therapy with close observation, which may then lead to mechanical intervention in the subsequent hours or days, or some sort of early mechanical support, whether it's an intra-aortic balloon pump, an Impella, or a VA ECMO. And Mike has developed a streamlined process wherein the individual initiating the shock team calls a hotline very similar to our STEMI hotline, and pages are sent to the members of the shock team, and we can get on a call via a sort of a ubiquitous Zoom link that can be activated at any time, and often it is at odd hours. And if it happens to be during the day, then we can converge on the patient physically. And this allows us to have a multidisciplinary discussion. So, much like Tony's cases, you know, even if it's in the middle of the night, whoever's making those decisions can feel backed up by their colleagues. One of the important components of this type of a process is to include it with some form of a quality improvement process and data capturing. So we capture all of our patient level data. The shock team working group reviews the data, and all of the outcome data and patient level data is compiled and then presented to the stakeholders, the clinical stakeholders, as well as the hospital stakeholders twice a year. That's kind of the process that we've come up with. Clearly, it's it's not a one size fits all, and not every hospital has the same kind of clinical resources, human resources, and clinical teams. So there is inter-hospital variability, but the framework that we've presented, I think, can be adaptable to your hospital and your existing infrastructure. There are a lot of stakeholders to engage, and anytime we're trying to refine the existing paradigm, it is a slow process. But Tony, I'm sure, would vouch for this, and others on the call that have implemented similar teams at your hospital would also likely agree that with a gradual process, the fact that you're able to show a standardized approach to what is otherwise sometimes a haphazard and chaotic environment with such sick people on high levels of medical support, often mechanically ventilated, where we're trying to make time-sensitive decisions. Having a process like this helps calm the temperature and helps show that we're able to make decisions that are otherwise high stakes decisions, but they're much more calm, controlled, and the fact that they're backed up by multiple folks within the same team that have consensus makes the process much stronger. To develop a meaningful quality improvement arm to a shock team is vital, and anytime where you're trying to implement a process like this, the focus should really be in trying to make sure that you're capturing the data, that you're intervening, the patients that you're intervening upon once you implement your shock team, and ensure that there's a constant revision and revisiting of your existing policies and improvement of your processes. So hopefully this was helpful in trying to describe the rationale and the evidence behind our existing shock teams, what the operational details of a shock team look like, and it gives you a lens into some of the challenges that many of us have faced in implementing these, or those of us that have done it even as early adopters, like our colleagues in Ottawa, for the last several years, what kind of challenges they've faced. So I think we'll open it up for questions and comments and feedback.
That's great. Thank you, gentlemen. So before I go to Dr. Lawless and Dr. Thériault, I got a few questions. First and foremost, as a closet PA catheter user, maybe I'll be able to not have to be embarrassed at times if we see a resurgence in it. I do think they have a role. albeit using it in other aspects of it. And I'm glad to hear that you value all members of the team. That's, I do believe we learn from our colleagues. I had the pleasure of working with some cardiologists who are now becoming who became intensivists, and certainly you learn a lot from other disciplines. So that's excellent. The question for both of you is often when patients are so in profound shock, it's the question of, is it all cardiogenic? What is the contribution from other forms? And I'm wondering, for sometimes it's pretty clear that it's cardiogenic, but for those cases where, there may be an aspect of something else contributing, what do you do in those circumstances? And do you give them the benefit of the doubt, or what exactly are you that fixated on the PA catheter? So I'll open up to both of you and see what your thoughts on that are.
Tony, did you want to give it a
Sure. So we've definitely had patients with suspected cardiogenic shock come through the CS pathway, and that's kind of why we're multidisciplinary. That's when usually we may lean more on our ICU colleagues as opposed to like the cardiology colleagues. But I've taken patients to the cath lab for a right heart cath in the middle of the night, and only to learn that their cardiac output is elevated and that something else is causing the hemodynamic disturbance. In cases like that, we're still, every now and then we think it's a stroke, and it's not. Like we have certain tests, certain tools in our assessment where we kind of back off and go, oh, this is something else. But I think, if there is concern that there's a cardiogenic shock, I think just early initiation and being aware of the pathology, just because the majority of cardiogenic shocks, especially those that go unrecognized or underrecognized, those are the ones that have the highest mortality. So just having even a group of doctors looking at a patient very carefully and discovering it's not cardiogenic, I think is still good in that we're identifying that they're sick and that it's not cardiac, so that we can get them the proper therapy.
Yeah, I totally agree. I think, Tony, you nailed it. I think it's a merit of having a multidisciplinary team. Often when we're having these discussions, the merit of having people coming from an unbiased, blinded kind of opinion, those that have not seen the patient, are not already anchored on potentially a diagnosis, helps bring up important questions. So, if the clinical picture is somewhat, is not a slam dunk, they're not coming with an acute MI, they don't have any pre-existing conditions that would clearly lead to a cardiac diagnosis. But sometimes the echocardiogram shows LV dysfunction or biventricular dysfunction. Some of the metabolics may be deranged. And then, the combination of the echo and the pulmonary artery catheter may show that there's a mixed picture sometimes. The cardiac index and the cardiac hemodynamics may be somewhere in the gray zone. Then having someone who's has not laid eyes on the patient ask important clinical questions like, what else could be going on here, or provide an opinion, really helps the team kind of recenter their focus and ensure that we're trying to only intervene for the right purpose. So there are many cases that are ambiguous. Not every case is clearly cardiac or clearly non-cardiac, and we rely on the team to help us make a decision. And often, in our case, we tend to be a bit more conservative. So we'll use our hemodynamics, we'll use our echocardiography, and we'll often make a decision to watchful wait and have close observation. And then as things evolve, we often meet about the same patient, 6 hours from the first meeting, or 10 hours, or the next day, depending on how things are going. So the shock team call often isn't just one, it's multiple.
Interesting. Thanks. Dr. Lawless.
Yes, thank you both for a great presentation. I think this is very interesting, and I think it's going to generate a lot of good discussion. I have a feeling people who weren't able to make it this afternoon are certainly going to want to join in and watch it later on YouTube or on their station. So because I think they're going to hear about how interesting this was. And I think as immersed as we are, I think from day to day in our work, I'm not sure how, and you probably have a much better view on this than I do, but how widespread it is currently sort of either in Ontario or I guess even just across Canada, that the shock teams are becoming more prevalent or getting implemented, or is there a sense of like how good, and kudos for doing all the work that you do to implement such an initiative in your organizations, because it's not easy, and it takes a lot of work and effort and passion and stick with itness. And so it's, but I'm wondering how, if you have a sense of how widespread they're becoming.
I think we have the luxury of having great colleagues at many of our partnering hospitals in Ontario. So, for example, my colleagues at UHN were instrumental in helping myself and our team implement our shock team in Hamilton. Similarly, in Ottawa, same thing. I think Ottawa and UHN were sort of the vanguards of shock teams in Ontario, probably the most early adopters. Since then, to my knowledge, and maybe others on the call can comment as well, I believe since then, Trillium has recently implemented a shock team. I believe South Lake is in the process, and as is London. So it is being adopted, at larger community centers as well as academic centers more and more. The area, in the last 5 years or so, it's probably the only area within cardiogenic shock that has shown a definitive mortality improvement since the advent of primary PCI. So it seems to be making its way, and even if it doesn't necessarily show a large mortality benefit in huge randomized trials like some of our other cardiac interventions do, some of the qualitative merits that we've described and gone through are mutually beneficial to all the systems of care. So they're clearly beneficial for patients as well.
I was going to ask about the mortality, only because I was a bit not wholly struck when you mentioned it at the beginning of the presentation in terms of that over the last sort of maybe 2 decades, there hasn't been a lot of things that have actually shifted the needles so much on mortality. And I have an idea how you might answer this, but are there some prevalent thoughts about why that is? Or is it, it could be patient demographics, I guess, or just the whole heterogeneity and difficulty measuring an actual outcome difference, or is it other factors you think?
Yeah, I think it's kind of the holy grail. It's probably perhaps partly the heterogeneity in presentation, partly also the fact that cardiogenic shock is also kind of multi-organ failure, liver failure, renal failure, which any cardiac intervention can't overcome necessarily. Just by augmenting cardiac output, we can't necessarily overcome all the coagulopathy and other things that go along with these patients. So that's why the key happens to be, so far from the best of our deduction, early recognition and appropriate patient selection, which shock teams lend themselves well to. And obviously lots of work is being done within the mechanical support space, within the inotrope space, and generally in critical care about what else we can intervene upon to help these patients fare better.
So I would have a couple of other questions, but I'm going to pass it to Dave, maybe to Josée if they.
Yeah, I'll go to Josée in 1 minute here. The quick question I have for you both is the role of the shock teams getting outside referrals. Like how do you see that, at whether or not that's happening or whether it will be coming? Because obviously not all centers have access to some of the mechanical devices. And so is there a role of the shock team for helping them temporize until they're able to come to such a center, or what are your thoughts? Maybe Tony, you can start with that. And
sure, I think in the US, where Detroit was really one of the first groups to embrace this shock team with a protocol, and one of the facets of that they developed was the whole idea of a spoke and hub model, where you kind of aren't just doing it at your tertiary level hospital, but you're trying to identify your partners in smaller centers that may not have access to cath labs or advanced heart failure, and trying to get them. So usually kind of the model has been, to build your program up at your local center and then sort of identify who your potential collaborators are, or referral centers are, or, we're Sudbury is a tertiary referral center for Northern Ontario, but still we like to, liaise with our colleagues at UHN or at Ottawa Heart. So if we have a truly refractory case that we think may need, advanced heart failure, whether it's LVAD or assessment for transplant. But I think, in HSN, the way we've done it is we've utilized the traditional pathways, whether it's, our virtual critical care team or just, critical, some ER doctor out in the community asking for help, and using that and then bringing the shock team in that way has been sort of the way that we've been doing things in Sudbury, but there are many different methods.
That's great. Thanks. I'm going to go to Josée, and then we'll go back to Dr. Lawless, and we'll have to wrap it up shortly thereafter. Josée.
Thank you to both of you for a great presentation. Starting to have a lot of gray hair here. I've been here for a little bit more than 2 decades. So I'd like to share my own, experience having seen this team develop as an intensivist that was often on their own managing these patients. It has made a tremendous impact in this collaborative approach, not only just for our perspective, because we get a chance to discuss, we get all these specialties involved, and we get the right time. We do get a good impression on where we're doing. We do have a plan. And the other piece too, I think these teams and this collaborative approach is actually very much patient and family centered, because from a family perspective, knowing that all these people that all have their own specialty come together and have a discussion and make a plan and present to the family. So it's not just left to one person to present that or have their impression. It really takes away from that interpersonal variability with the different specialties. So I've seen a great difference and a great impact for our patient and our families. So thank you for plowing the road to these shock teams. So I think our families, our patients are very much at the forefront of these teams. I was curious. I have a few questions, but I know that Dave and Bernard take a lot of time. So I'm curious if any of you have used these teams in cardiomyo or septic cardiomyodepression. So we have these septic patients that develop severe cardiogenic shock on top of their sepsis. And have you had any experience with that? And then I would like to dive a little bit, after this question, I'd like to dive a little bit into how can we help our smaller centers? So I'd like to see your experience with the cardiomyodepression in septic shock, and then I can ask the questions for our smaller centers.
Thanks, Josée. Firstly, I not to belabor this, but I cannot overstate the merits of the collegial spirit that comes with shock teams, as you've suggested. Of course, it's patient-centered, family-centered, but the impact on our clinical teams is both tangibly and intangibly just enormous. I think that with respect to the septic patients with myocardial dysfunction, we've seen a number of cases. We saw them during COVID. We've seen them with group A strep sepsis. We've seen them with strep pneumosepsis. We've seen them with a handful of other presentations, up to and including things like a acute pheochromocytoma with kind of a myocardial crisis. We generally shy away from mechanical support in those patients, but we do use invasive hemodynamics to guide our inotropic and vasopressor selection. We've generally found that patients with clearly documented sepsis that do also have concurrent evidence of myocardial dysfunction, both on echocardiography and invasive hemodynamics, generally have not fared as well as those with just clean, clear-cut cardiogenic shock. So our threshold to intervene with any device therapy in those patients is higher, but we do use invasive hemodynamics pretty regularly in those patients with sepsis and associated myocardial dysfunction, so we can tailor their hemodynamic inotropic therapy. I think, Tony, if you want to comment on that, as well as maybe the second question as well.
Sure. So we have had shock team activations for patients that have had a mixed picture, sepsis in terms of underlying, ischemic cardiomyopathy that was there before, or someone who had, I presented the case of someone who had Takotsubo, which is, the ultimate form of, myocardial depression in a critically ill patient. Usually we have shied away from mechanical support, just echoing my colleagues, we have done invasive hemodynamics to help assess and guide therapies for those patients. But in general, even some of our mechanical support patients who are at our center, Josée, before I came here, I think some of them, those patients tend to have much higher mortality. So again, we try and limit our use for MCS in those patients. And I'm sorry, Josée, what was your second question?
No, so two things. So from our smaller center perspective, if they were to reach out, what would you want them to start with, and what type of information would you like them to provide you if they are reaching out and they say, I think I have a cardiogenic shock patient? So I'd be curious with that. And any plans for, this might be more at the provincial level, but any plan for devising like a cardiogenic screening tool that could be shared and standardized, so to really target those patients in phone calls? So I'm curious about your thoughts on that.
So I think it really depends. I think that Dr. Amin and I probably have a different referral basis, but usually the calls that I get, or I choose to involve, my critical care colleagues in, are usually sometimes it can be just very bare bones information, like what was the history of presenting illness, what have you done for them, and what's their ECG and echo show. If I have those sort of things, then I have a pretty good idea of what's going on. But I certainly like your idea of giving our colleagues out in non-cathing hospitals the tools so that they can, start the process.
Yeah, just to wrap up as well, I totally agree, Tony. I think that the regionalization of cardiogenic shock care is probably in our near future. And our referring hospitals, smaller community hospitals are extremely important stakeholders in this process and the care of these patients. So to develop a regional model wherein we can have clear communication, similar to how we do with our respiratory ECMO kind of referral guidelines, to have something similar for our cardiac patients is increasingly important. And I think just kind of quick practical things that can be done at the bedside are, kind of feeling for cool extremities, presence of clinical heart failure findings, and then use of point of care ultrasound, whether it's in the emergency room, which is more now widely available in most emergency departments, no matter where you work, with the exception of few. And so the combination of those, as well as having colleagues that you can reach out to at a local regional center, I think it lends itself well to a regional system for cardiogenic shock.
Thank you very much. Greatly appreciated. And
Well,
I'm looking
gentlemen,
forward, looking
Yeah.
forward for more development and dissemination and socialization of these aspects. So thank you again.
Thank you both. I just want to highlight again our survey for feedback. We asked all those who are listening to please do that. Bernard, I don't know if you have any final thoughts. I know you had a final question, but you're on mute as well.
Shoot, forget that. I probably have a few other questions, but I know we're at time, and I think I'm very appreciative of the presentation. So thank you both for the time and the commitment to being here today, and for doing the presentation and the tremendous amount of work that goes into getting it to this point in terms of your desire and your passion to have these teams implemented at your hospital. I'm sure that's not an easy task in terms of the multidisciplinary component of it, especially getting everybody on the same page and getting the support you need to do that. So you're setting a pathway, I think, for other people to be able to borrow from and learn from that. And I think it's tremendous. And I really enjoyed the presentation today.
Thank you again, both. And thank you to CCSO for all the work they do on helping us host this.
Thanks, everyone.
Thank you.